Hello and welcome to this ECG in a minute video where I'm going to talk through two ECGs very quickly with one commonly missed abnormality, and that's high lateral STEMI. So at the end of this, you won't miss a high lateral STEMI ever again because I'll show you exactly the principles you need to be sure that you always spot it. So here's an ECG. It might strike you as looking pretty abnormal straight away. You might think, how would I miss anything on that? Well, let's just zoom in and you can take a look at the obvious abnormalities on this one. And what might immediately strike your eye is that there's deep ST depression in lead 3 and deep T-wave inversion, and you realize that that's grossly abnormal. You might also then look at lead AVF and you see the same thing, a bit less marked, but there's ST depression, T-wave inversion. Now you might think that that's it, and you might think that's just inferior ischemia. It's not. In fact, ST depression in inferior leads is rarely due to inferior ischemia. It's usually reciprocal change. So if you see it, look very carefully elsewhere in the ECG. Look at the anterior leads and look at the high lateral leads to see if there's ST elevation, because then it's a STEMI. And if you look at lead AVL, you will see an obvious abnormality. There's a massive T wave. It's higher than the R wave. It's really peaked. And there's ST elevation, which is easily missed, but it's clearly diagnostic of a high lateral STEMI. I'm going to draw a line here just to show you that ST elevation if you didn't notice it before. Look at lead 1 as well, the other high lateral lead. The T wave is as tall as the R wave. It's a high lateral STEMI. This patient had a troponin elevation. It went up to about 200 nanograms per litre, and they had an occluded diagonal. Now, the next ECG I'm going to show you is a bit more subtle, but if you follow the same principles, you won't miss this very subtle high lateral STEMI that was actually missed in clinical practice. So let's just bring that up for you so you can see it a bit more clearly. Once again, your eyes might gravitate towards the lateral leads, where you might notice that there is some ST depression and certainly some deep T-wave inversion in lead 3. Looks a bit abnormal. Look at lead AVF as well, and you know what? That ST segment really sags downwards going into the T wave. It does look like you've got ST depression in those leads, not as marked as the previous one, but having seen it, have a very careful look at the high lateral leads. Look at AVL just here. And once again, you can see that there's ST elevation, not so much T-wave peak. I mean, the T-wave is more than half the size of the QRS complex at least. So it looks a little bit peaky, but there is some ST elevation as well. If you draw that line, it's clearly not as marked as in the previous ECG, but it is up compared to the baseline. That is a high lateral STEMI. And this patient, although it wasn't recognized, and you can understand why because it's so subtle, they also had a troponin elevation that went up to over 200 nanograms per litre. They also had an occluded first diagonal branch of the LAD. So that's high lateral STEMI in a nutshell. Follow these principles and you'll never miss one ever again. Thank you.